Hello everyone, I am Dr. Jyoti Verma. In this class, we will discuss blood conservative measures. Blood conservative measures are really important for an anesthetist to optimize the condition of the patient. They are planned perioperatively, so there are measures preoperatively, there are measures intraoperatively, and there are measures postoperatively which help in blood conservation. To summarize, we have noted points which are used as blood conservative measures in preoperative period, intraoperative period, and postoperative period. Preoperatively, there are patient factors and surgical factors. Patient factors are such as patient having preoperative anemia, patient having any history of bleeding such as GI bleeding or gynecological bleeding, patient is on any blood thinners, on any anticoagulant or antiplatelet drugs. Surgical factors are patient is undergoing some major surgery such as cardiac, spine, major lower limb surgery, multiple trauma, or patient is undergoing liver transplant. It also depends on the experience of the surgeon. Intraoperative blood conservative measures, there are many factors. We will discuss each of them in detail. We are just listing them. Patient positioning affects blood loss. Temperature of the patient affects blood loss. Same regional anesthesia, blood pressure, baseline blood pressure of the patient affects blood loss. Operative technique we will discuss in detail. Hemodilution is also affecting blood loss. Then cell salvage can be used to conserve blood, and antifibrinolytics can be used to conserve blood. Post-operatively, we have to observe the patient. We can use point of care testing. We have to apply pressure dressing. We can use cell salvage post-operatively. Lab testing can be done, and blood transfusion, if required, can be done. Discussing each of the factors. First, preoperative. Preoperative, as we have discussed, there are patient factors, there are surgical factors. Patient factors are patient is having anemia. Pre-op anemia is defined by WHO as less than 13 gram per deciliter for males, less than 12 gram per deciliter for females, and less than 11 gram per deciliter for pregnant females. So we have to find the cause of anemia and treat accordingly. So anemia is sorted. We will first find the root cause of anemia and then treat. History of bleeding, we have to see what type of bleeding is there. Is there any GI bleed? There is history of trauma, there is gynecological bleed, and we have to find the cause and treat accordingly. And if the patient is on anticoagulants and antiplatelets, we have to follow the ASRA guidelines and then stop according to the risk of the surgery or according to the nature of the surgery or patient. If the patient undergoes major surgery, then we have to consider for blood conservative measures. Talking about causes of preoperative anemia. Preoperative anemia might be due to impaired RBC production, there is less production of RBCs, or impaired production of RBCs seen in iron deficiency anemia, seen in vitamin B12 deficiency, thalassemia, and renal failure. So we have to see for the cause and then correct it. If there is increased breakdown or hemolysis seen in sickle cell anemia, hereditary spherocytosis, there is transfusion reaction, or patient is having any infection, or there is premature destruction due to intrinsic factors. And if the patient is having blood loss due to GI bleed, gynec bleed, or there is history of trauma. So we have to see what all is causing anemia to the patient and we have to correct each of them. If the patient is on anticoagulants, we have to balance, we have to see the risk and benefits of stopping that drug. For detail, we have to see the ASRA guidelines. Just to complete, aspirin can be continued, clopidogrel has to be stopped 5 to 7 days approximately, and warfarin 5 days before the surgery. These are the preoperative measures. After this, we will discuss intraoperative measures. So, patient positioning. Suppose the surgical field is above the heart. When the surgical field, suppose this is the heart of the patient and the surgical field is here, the position of the surgical field above the heart leads to less bleeding. Venous drainage should not be compromised. Compromising venous drainage might lead to increased bleeding. Prone position increases IVC pressure and might increase blood loss. Talking about temperature, we have to do temperature monitoring. Hypothermia alters enzyme functions, leading to effects on fibrinolysis and decreases platelet function. ODC shifts to left in hypothermia, leading to decreased tissue oxygenation. If we talk about regional anesthesia, as we all know, regional anesthesia decreases the sympathetic tone and further decreases the mean arterial pressure, which further decreases the blood loss. Talking about blood pressure of the patient, we can follow hypotensive anesthesia, and we have to maintain vital organ perfusion. This we have to remember, that in practicing hypotensive anesthesia, we have to maintain perfusion of vital organs. We can use TIVA, we can use opioids, we can use beta blockers such as labetalol, esmolol. We can use SNP, which is arteriovenodilator. We can use NTG, which is venodilator. We can use clonidine, magnesium sulfate. So these are the techniques, these are the drugs we can use to decrease the blood pressure, but we have to remember that we have to maintain the vital organ perfusion as well. Operative technique we will discuss in detail in a while. Hemodilution. Hemodilution can be done normovolemic hemodilution and hypervolemic hemodilution. Normovolemic hemodilution decreases hematocrit, decreases viscosity, tissue perfusion is increased, blood flow is increased, and blood loss decreases. Hypervolemic hemodilution might lead to circulatory overload, and we need to take care of it, and we have to be cautious in patients who have cardiac disease. Cell salvage is a technique for conservation of blood. It is collects blood, processes it, and reinfuses it into the system, into the patient himself. It is indicated when the anticipated loss is more than 1 liters, or it is more than 20% of estimated blood volume loss, or the patient is at high risk of bleeding, or the patient has a very rare type of blood group which is not available in the blood bank. Contraindications for cell salvage are, it requires appropriate training. So training is required. Other causes are pharmacological. Suppose the patient is taking clotting agents, or we are using an irrigating solution such as alcohol or betadine, or the blood is contaminated by methyl methacrylate, such as which is used in orthopedic surgeries, or biological components such as bone cement fat or bone, or patient has any malignancy which is contaminating the blood, or the patient has sickle cell anemia. So in these cases, cell salvage is not used. And then we can talk about antifibrinolytics. Antifibrinolytics are epsilon aminocaproic acids and tranexamic acid. They bind to plasminogen and they prevent conversion to plasmin, which plasmin breaks the fibrin. So fibrin is not broken, so clot is maintained. So they help in maintenance of clot. We can use tranexamic acid. It is more potent, 6 to 10 times more potent. It is used at a dose of 10 milligram to 30 milligram per kg loading and 1 milligram to 15 milligram per kg per hour. Other drugs that can be used are aprotenin, desmopressin, and recombinant factor 7A. Operative techniques, as we have discussed earlier, operative techniques we will discuss in detail. So we can go opt for minimally invasive surgery, such as instead of an open surgery, we can opt for a laparoscopic surgery. We can ask for an experienced surgeon to perform the surgery. We can, if possible, we can use tourniquet. We can ask the surgeon to use tourniquet, and we have to note the time, we have to note the pressure, we have to note the time, pressure and location of the tourniquet. So usually approximately the pressure of the tourniquet is usually 50 to 100 mm of Hg above systolic BP, and we have to note the time. It is usually allowable to 90, approximately 90 minutes for upper limb and 120 minutes for lower limb. Then we can consider vessel ligation. Vessel ligation is usually used in vascular tumor removal and in pneumonectomies, or in areas where vessel ligation is possible. Then infiltration of with local anesthetic with ADR. Adrenaline causes local vasoconstriction. Infiltrating with local anesthetic with ADR leads to vasoconstriction and bleeding decreases bleeding. This can be used in patients with in whom there is large surface area is used for skin grafting. Then diathermy. Diathermy is considered to decrease blood loss. Then we can use topical vasoconstrictors such as ADR soaked gauze pieces. Then we can use fibrin glue. These are the operative techniques which help in blood conservation. Postoperatively, postoperatively, we can observe the patient. We can see the patient clinically. If the patient is having any pallor, if the patient is having respiratory distress, or patient is having tachycardia or hypotension, and we can see for the drain collection. Then we can use point of care testing. Point of care testing helps testing bedside only. We can use it for hemoglobin, platelet, INR, PT, APTT. We can make the use of TEG-ROTEM in transplant surgeries, especially in liver transplant surgeries. We have to use a pressure dressing. We can use cell salvage in if the cells facility is available and if the patient is having rare blood group. Lab testing can be done and blood transfusion can be done post-operatively. So these are the blood conservative measures. If you like the video, please give it a like and share it with your colleagues. Thank you so much.